I am a rheumatologist, and I have worked primarily in rheumatoid arthritis. Uh, but today, during the pandemic, I was deployed actually to work in the front lines with hospital medicine. And well, these are my disclosure first of all. And one of the first part of this conversation tonight, I want to share a little bit about that experience of caring for patients with COVID-19 from the rheumatology standpoint. Um, and that is the first part of the conversation. Then the second part of the conversation for today, of the objectives of today's conversation, is about describing briefly the outcomes from COVID-19 in patients with rheumatic diseases, in an overview of the ACR COVID-19 vaccination recommendation. Okay. So to begin, I want to go over that experience of what was the big wave that we had in New York City in March of 2020. And as I move into the medical wards as a rheumatologist, I started to, brainstorm what could be my contribution. I didn't see that as a rheumatologist, there was a role for me because I thought this was going to be something related mostly to critical care, cardiology, pulmonary anesthesia, and infectious diseases, but not necessarily for a rheumatologist. But what was happening at that time, especially in New York City, was that this virus that we know is highly transmissible, highly lethal without treatment at that time. Now we have some treatment for it, were extraordinary high just already by February. And then my work consisted pretty much of statistical analysis, preparation of manuscripts, write research proposal, develop interventions, but not necessarily being a hospital medicine doctor. But then when I went into the medical wards, one of the things that I realized is that, well, we know that there are other viral infections that have a very heterogeneous presentation, right? There is herpes, where it can be just as simple as a cutaneous condition, but then some people can have encephalitis actually from herpes. And the same happened with influenza. Shingles can be localized or can be actually disseminated and life-threatening. So then I said, this could be actually part of the reason that some people with COVID-19 are completely asymptomatic and others died, for multi-organ failure. So it's sort of I started noticing the parallel in these presentations. Then the other thing is that we also have heterogeneous presentations in patients with rheumatic diseases. Like in lupus, some people go in dialysis and some people have lung problems, where others simply have a rash. And then I say, there is another parallel here. And then in terms of what is happening with infectious diseases and what happens with rheumatic diseases, is that there is an overactivation of the immune system in order to fight the infection in the cases of an infection, and a pathology that happens from overactivation of the immune system that attacks healthy organs in the case of an autoimmune condition or rheumatic disease. So that is the parallel also in the pathophysiology of what we know in regards to an infectious disease and a rheumatic disease. But then this immune reaction, even in the setting of an infection, can also lead to worse outcomes and can trigger then an autoimmune process. And that was not the exception of what we saw in the medical floor. So as I am finishing my rounds in the medical floor, I started hearing in the doctor's lounge when I'm typing all my notes in the medical record, the hospital medicine team that has been already spent over a month caring for these patients saying like, this is a very frustrating disease. We pretty much feel that we are babysitting these patients until they crash, sometimes just die, and they were very frustrated and about the fact that they couldn't do anything. As we as doctors, we really want to do something to help our patients, and during that times it was very frustrating. And they also highlight this point. There is a critical zone that is between day 7 and day 12 of symptoms of COVID 19. And that is the time where, after they have a holiday and they start feeling fine, day 7 arrives and they started to experience then more fever, GI problems, and then worsening in their respiratory failure. But if they arrive between day 14 or 16 of symptoms from COVID 19, they tend to do quite well. And that was pretty much the course that I was taught was the course of patients with COVID 19 once they arrive acutely ill to the hospital. And then another thing that happened was around that they were estimating that around 40% of the patients in their services had a lot of had clots. It turns out that it was around 20%, which is still high. But we also know that patients with lupus and other autoimmune diseases can also have or develop blood clots. So you see, there is a lot of parallels to what I'm doing, and I say, is this something that I could make a contribution, or a rheumatologist might play a role? And then this was the other thing that they were commenting that not all of them get fever, but reports of that came from China, that came from Italy, and that came actually from the United States later in 2020 said that around 75% to 77% of people do experience fever. But yes, not everyone experiences fever, but that's still a pretty high number, right? And as we know, also, people that have fever can have are triggered by interleukins of the immune system, and those are pretty much interleukin 1, 6, and 18. Okay, so keep those interleukins in mind, because we're going to be talking about that in a little bit, about how this immune response play a role, and also how sometimes people with rheumatic diseases could also do worse in the setting of COVID-19. So then with this, we were talking a little bit about, are these people having cytokine storm syndrome? And the manifestations of cytokine storm syndrome can range from mild flu-like symptoms to severe life-threatening systemic inflammatory response syndrome. And we see those in patients with sepsis and advanced sepsis with any infection, either bacterial or viral sepsis. You could still have multi-organ system failure that might have a component of cytokine storm syndrome. Another virus that also has been associated with cytokine storm syndrome is Ebola and dengue fever. And that is why they can have these hemorrhagic kind of manifestations. And interestingly, in the case of COVID, it's more of a clotting manifestations that people have. But another series of symptoms that happens in the presence of cytokine storm is fever, especially if it is driven by interleukin 1. So other symptoms include fatigue, headache, rash, diarrhea, arthralgias, and myalgia. So you see the first bullet talks about the severe multi-organ failure, and then fever, malaise, just the mild cases of COVID. We're seeing sort of like the broad spectrum that COVID-19 presentations have, and also goes in parallel with the broad spectrum of presentations that you can see in patients with cytokine storm syndrome. Other aspects to take into consideration is that people can have also altered level of consciousness and impaired cognitive skills. We noticed that also in the setting of these patients, and that has been also reported in the case of rheumatic fever, where people develop chorea and involuntary movements as a result of having a strep infection. And remember, diarrhea is also another sign of cytokine storm. That has been also reported with influenza, that influenza can cause also diarrhea. Many patients also with COVID-19 experience diarrhea. So do people with adult onset Still's disease, or even children with Still's disease. It's a common manifestation to see diarrhea, and in those cases, it's highly related not totally confirmed or explained by, but related to this cytokine storm syndrome, which also has a very heterogeneous presentation. And finally, the neurologic toxicity might occur several days later. So once we get into the floor, we start seeing these patients with COVID-19 manifesting these issues with cytokine storm syndrome and severe disease. So we postulated the following hypothesis, which is that patients demonstrating laboratory evidence of cytokine storm syndrome and increased requirement for oxygen may define a window of opportunity where we could intervene and avoid the need for mechanical ventilation. And that was by the use of interleukin 1. Remember, I mentioned earlier that one of the major interleukins that play a role in cytokine storm syndrome is interleukin 1. And interleukin 1 is also the one associated with fever, the incidence of fever. So, in those patients with COVID 19 that do experience fever, that might be the one that cytokine storm driven by interleukin 1 is the pathway that can explain the clinical presentation. So because of that, then we decided to use this antagonist for interleukin 1, which is called anakinra. Anakinra is an FDA-approved drug for rheumatoid arthritis, and it's actually used also quite frequently for adult onset Still's disease and for children also with adult disease. But in this setting of cytokine storm syndrome, it is also has shown some benefits in studies back in the late 90s in the setting of sepsis. So we decided to see, well, let's see how we can make a contribution during this crisis and see what could be a good phenotype of patients that could benefit from IL-1 inhibition, right? And the reason is that at that time also there were multiple trials focusing on IL-6 blockade, which are tocilizumab and sarilumab. But they were using these medications once patients were in the ventilator. And once patients are in the ventilator, that means that they have already developed damage in their organs. And these drugs are not going to give them new organs. We have to stop the immune response before they lose their their function. So that is why we decided to intervene within that window of opportunity that there is enough risk for them to go into intubation that they can also get a high benefit from this medication. And what we identify is that those that had a molecular COVID test, a positive COVID test done, they had documented fever, because if they did not have fever, then IL-1 was not involved in the cytokine storm pathophysiologic pathway. And they had to have also either documented fever or historic fever. They must be 18 years of age or older, because I am an adult rheumatologist. But the most important part were these last two. Ferritin has to be over 1,000. Why? Because that is also, the higher the ferritin, the more specific is for cytokine storm. If we choose a ferritin of 700 to 800, we could be misclassifying just a normal inflammatory response with cytokine storm syndrome, severe cytokine storm syndrome, which might not be the case. So in order to make sure that we were indeed dealing with cytokine storm syndrome, we increase the cut point to diagnose this as one greater or equal than 1,000. Now, number 4 is the most important. As physicians, we treat patients, we don't treat laboratories. And it was indeed necessary for these individuals to have severe respiratory failure, because if they did not have severe respiratory failure, even in the presence of these laboratory abnormalities, they still did well without any intervention. Are those that are on the verge of needing a mechanical ventilation that were the one that benefited the most. So we did not use this drug unless people have a severe respiratory failure. That this means using a non-rebreather face mask, and they still are saturating 93% or less in their oxygenation. So these are the main categories that we found useful. When we look at these other criteria in the bottom, to have at least two of the following criteria, such as lymphopenia by less than 15 cells per microliters, or LDH greater than 300, or D dimers greater than 1000, those were not that informative or that consistent with the deterioration of the respiratory failure, which was the most important uh, characteristic in this phenotype. So what were our results? This is a case series that we published, and we actually were consulted in 29 patients in a period of around 3 weeks. Actually, it was quite um, intense, those 3 weeks. And among these, 14 met criteria, all the criteria that I mentioned below before. 11 receive anakinra, but those that receive anakinra within 36 hours of the onset of the respiratory failure did not need mechanical ventilation, never made it into the ICU, and were able to be discharged home on room air. Now, those that were already, when we were consulted, met criteria, but they had been already in respiratory failure for more than 4 days, all of them require mechanical ventilation, which highlights why patients that have already accumulated damage or some organ involvement severe for several days is harder to catch up. And that supported also the hypothesis that treating early is important to prevent them further damage. And even though two people were discharged home on room air, but they were discharged home with a lot of morbidity. They were limping. They needed physical therapy. They would still have some chronic cough and other issues that the goal is to prevent them, so they can still enjoy their quality of life without having to go through the need of being in the ICU or being on the ventilator. One person died among those that received anakinra for more than that had respiratory failure for more than 4 days. This person that died, we stopped anakinra after the second days because a culture came back positive for gram-positive cocci. It seems that he already had that super infection. So in 2 days, it's unlikely that the infection was acquired by or as a result of the medication, but probably that he had it at the time that we started the medication. Then 3 patients did not receive anakinra, either because we didn't have it available in the hospital, it was the pandemic, everything was running short, or because they refused to get it, as we had to obtain consent for the off-label use of this medication from the patients, and some patients just said they did not want it, and all of them require mechanical ventilation. Now, one person was extubated, was still in the hospital. This as of June 2020. Actually, I think that one person that was still intubated passed also, and then one person was discharged home. So this also highlights that there might be a role for repurposing rheumatic diseases medications in patients with severe COVID-19. So in summary, from this first experience that we had in the spring of 2020, patients with the more severe forms of COVID-19 may demonstrate an immune response skewed to a production of inflammatory cytokines or cytokine storm, right? And this cytokine storm syndrome, in the presence of high oxygen requirements, may identify that window of opportunity for prevention of mechanical ventilation through the use of IL-1 inhibitors. And we published this in June of 2020, and some of these, some studies actually were designed a little bit after that, using our approach, which is very exciting. And now anakinra is under review at the FDA for emergency use authorization, based on that trial that was, I think they started recruiting not much after our experience. So that's very exciting to see. So this experience was highlighted in the New York Times, and we were able to disseminate the knowledge that we acquire by using these medications. HSS also highlighted this in the rheumatology annual report. in scientific journals. This is our publication, made it made it in press, formally in print in December of 2020. And that gave us the opportunity also to contact patients from the Spanish speaking community. And that is why we're here today, also to reach out and to doctors from the Asian community, so everyone is on board about the knowledge that we have been able to generate as a result of this experience with the pandemic. I had to post this because this was one of the most exciting experience in New York City. That after a 12-hour shift, you get out to just go home, and this is what you found: people clapping, an entire city just excited to see you go home and feeling like a superhero. Even though we really did not think of that, but it was very rewarding and made everything worth it. So let's move on now into the second objective of today's conversation, which is about discussing briefly the outcomes of COVID-19 in patients with rheumatic diseases. So I'm going to go over two papers that were published recently. And then because there is so much data, and the take-home message is still pretty much the same. So this first paper talks about the factors associated with COVID-19 related death in people with rheumatic diseases, not one disease in particular, or lupus, or RA, or vasculitis, but all of them, which actually I think is more important, as some of our medications are also used across diseases and not only for one disease. And this is a result from the COVID-19 Global Rheumatology Alliance physician-reported registry. So for those of you who you're not familiar with, it's very interesting. The Global Rheumatology Alliance started on Twitter, where a bunch of physicians started just exchanging threads about the questions that they were having, the cases that they were seeing, and the fact that many rheumatologists were being deployed to the front lines. And this was a worldwide effort to collect data on patients with rheumatic diseases, and the physicians were the ones that were entering the results of the patients that they were following, either through telehealth, phone calls, and so forth, in terms of what were the medications that the patients were getting for the rheumatic diseases, how many of them were getting COVID, and what were the course of their infection with COVID, given the fact that they were on an autoimmune disease and had given the fact that they were on an autoimmune, given the fact that they had an autoimmune disease and that they were on a immunosuppressant. That's what I meant to say. Thank you. So this registry of the Global Rheumatology Alliance was launched in March of 2020. Data was entered voluntarily by rheumatologists or under supervision of rheumatologists. Patients were eligible for inclusion if they have a pre-existing rheumatic disease and a COVID-19 diagnosis. And the data entered either directly into global or European data entry system or transfer from national registries. And I believe that some of these data is actually available online. I think last time I checked was the end of last year, and you could enter to their website of Rheumatology Global Alliance and get some of the results of these surveys. So for this study, they used data collected before July 1st of 2020. And the Americas were further divided into North and South America. And they stratified diseases in terms of inflammatory joint diseases. Those will be rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. Rheumatoid arthritis was a subset of that inflammatory joint disease, and connective tissue diseases such as lupus, scleroderma, and vasculitis. This table it was huge, so I divided into just several slides, and I put in the red boxes to guide you a little bit better about what are we talking about. So this is a multivariable logistic regression analysis to identify what were the factors of patients with COVID-19 who had a rheumatic disease that associated with death in these patients, right? So among all patients, there were a lot of patients, 3,705 patients. And among all patients, the independent risk factors for death in patients with COVID-19 was, as you can see, age greater than 75 with an odds ratio of 6.18, hypertension, and CVD. The same factors were associated with the risk of death in patients with inflammatory joint disease and also in patients with rheumatoid arthritis. Now, in patients with connective tissue disease, having also chronic lung disease and having chronic kidney disease, which makes sense for people with lupus, were also independent risk factors for mortality from COVID 19. Now, this other part of the table, this is the second part of the same table, showed that for patients, and I think this is the most important one, is this first red box here, is that high, moderate, or severe disease activity versus being in remission or low disease activity. These are for patients with inflammatory diseases, for patients only for rheumatoid arthritis, or patients with connective tissue disease or vasculitis, for everyone. Having high, moderate, or severe disease activity was an independent risk factor for death in patients with rheumatic diseases that got infected with COVID-19, which means that not only the medications, but more importantly, the disease activity was something that was remarkably important in the risk of dying. Now, Rituxan is one of the therapies that across the board also was an independent factor for mortality from COVID-19 in patients with COVID-19, and so did glucocorticoids. So the take-home message is that patients with rheumatic diseases have several predictors of mortality from COVID-19. Age greater than 75, comorbidities such as hypertension, coronary artery disease, renal and pulmonary disease, but more importantly is disease activity, something that people from the general population did not need to worry about because they don't have these kind of autoimmune diseases. So targeting then or controlling disease activity is important as long as it is used with medications for rheumatic diseases that do not include Rituxan, because Rituxan can increase the risk of death, and that do not include glucocorticoids. Okay? So those are the main take-home message about this. Now, this other article was also, this is now localized to Sweden. And it discussed also the impact of COVID-19 pandemic on morbidity and mortality in patients with inflammatory joint diseases and in the general population. So this study consisted of 2 open cohorts of individuals above 18 years old. It included patients with prevalent rheumatoid arthritis from March 2015 to September of 2020. Included also other inflammatory joint diseases like psoriatic arthritis, ankylosing spondylitis, spondyloarthropathies, and juvenile idiopathic arthritis. Each individual was matched on the year of birth, sex, and region in the Sweden population register and required to be alive and free from inflammatory joint disease at the time their index individual qualified for this cohort. So then once they look into the patients that already developed that, they already had established inflammatory joint disease to join the once they joined the analysis for this paper. The outcomes of this paper included death from any cause based on death notification from tax agency, and death from COVID-19, hospitalizations, or admissions in intensive care unit. These are the characteristics of the patients. And these are patients with RA, patients with other inflammatory joint disease, or all inflammatory joint disease combined. So as you can see, all combined is 110,000 patients, even a larger sample. Mean age was around 62 for everyone. Very few had cancer. Most of them were women, also like we see in most cohorts of rheumatic diseases. And the majority were born in Sweden. I think those are the main take-home messages from these table 1 and characteristics. But then these are the important results, I think, for this cohort. It said during the first period of the pandemic, patients with inflammatory joint disease had approximately 1.5 to 2 times higher mortality from any cause than the general population. Um, this increased risk was not higher during the previous year, and could almost entirely be explained by comorbidities and socioeconomic status. Now, once COVID-19 hit, the risk for admission to hospital due to COVID-19, which was 0.5%, this 0.5% translate into an absolute of zero point 0.2 per 100% compared with the general population. So that risk of admission in patients with inflammatory joint disease was very, very small still. Admission to the intensive care unit was only 0.1 per 100%, and the risk of death was 0.1%, which translates into an addition of 0.03 per 100% among patients with inflammatory joint disease. So these numbers tells you that while the risk was increased, it was still lower. It was still low, relatively speaking. And again, the limitation is that this study was done in Sweden and it was limited to inflammatory joint disease. And in the previous paper, included also people with lupus, and patients with lupus tend to have also a lot more comorbidities like pulmonary and renal problems that is not present necessarily in patients with inflammatory joint disease. Then here, the increased relative risks were not specific to COVID-19 related outcomes, but present also for hospitalization and death due to any cause. And for me, that is important because this is the other phase of the pandemic, right? People stop paying attention to their other conditions and focus only, do I have COVID or not? And if I don't have COVID, I don't need to seek care. But then they did not pay attention to their diabetes or their high blood pressure, or even the fact that some of them were experiencing some form of TIA or strokes. So those things were very important to address, and those were really postponed by many of our patients. Now, patients treated with biologic and targeted synthetic DMARDs were, on average, not at higher risk for COVID-19 related outcomes than those on conventional synthetic DMARD. Now, biologic and targeted synthetic DMARDs include adalimumab, etanercept, abatacept, but then targeted synthetics includes tofacitinib and baricitinib. Those are the daily pills that they have to take. And conventional synthetic DMARDs include medications like methotrexate, sulfasalazine, and hydroxychloroquine. So immunosuppression degree that you get from biologic and targeted synthetic DMARDs is high and more aggressive and more profound than those in conventional synthetics. So the idea is, well, is higher immunosuppression a higher risk for is it a higher risk for infections with COVID-19? And apparently, according to this study, it wasn't necessarily the case. But remember what I mentioned in the previous study, high disease activity was an independent risk factor for mortality. So the use of these aggressive medications were probably not necessarily protective, but what protected them was that these high immunosuppressant medications allowed them to control their disease and by default then lower the risk of mortality. I thought that that was very interesting that we see that dynamic repeating and repeating. Now, Rituxan and JAK inhibitors, so Rituxan and JAK inhibitors were associated with worse outcomes from COVID-19. But in this particular study, this data is very limited because it was only few cases or only few people that were on these medications. Okay, now let's look at the last part of our conversation that will be focusing on the vaccination guidelines for COVID-19. I think I have probably 3-4 slides on this. And then we conclude our conversation today. So in a nutshell, COVID-19, about COVID-19 vaccines, let me have some water. mRNA vaccines work by inducing the production of antibodies in our body to prevent coronavirus from infecting us. These vaccines are produced completely in vitro and in the laboratory, which also facilitates production. This is unlike other kinds of vaccines that require other substrates and eggs and other things. So the production of mRNA vaccines can be done quickly, quicker than other platforms for vaccination. So there are still some investigations about how this technology is working. So far, now we have more data that it has worked well. But the reason that sometimes the delivery and the storage of these vaccines is difficult is because as this technology is new, we really want to make sure that we keep it as stable as possible. That is the reason that, excuse me, the need for very low temperature refrigerators to be available for storage, especially of the vaccines from Pfizer and Moderna, which are the mRNA vaccines. So the efficacy of COVID-19 vaccine in patients with rheumatic diseases. So vaccinating individual patients, these are also, let me step back, let me explain something before I carry on. So this task force that I'm going to be referring to is the American College of Rheumatology Task Force that was put together by the college to establish recommendations for vaccinations on patients with rheumatic diseases regarding the use of COVID-19 vaccination. So they recommend vaccinating individual patients, no matter what, hard stop, okay? And the expected response on vaccination on patients with inflammatory arthritis receiving certain immunomodulatory therapies will likely be blunted. And that has been, the task force did not have much data when they came up with this recommendation regarding how much the immune response will be blunted. And instead, they were using data from other vaccines like the shingles vaccine and the influenza vaccine, where we know that indeed some medications like methotrexate and rituximab lowers the capacity of the body to produce antibodies against shingle and influenza. And they anticipated that extrapolating that data into the COVID-19 was still supported that it's likely to be blunted. Now, as of today, now 2021, July 2021, there are a few articles that have come up that indeed have shown that particularly rituximab does lower the capacity of individuals to produce higher amount of antibodies against COVID-19. So that is why they also came up with specific recommendations regarding how the frequency of the dosing of rituximab should be done in preparation to receiving the COVID-19 vaccine so that the individual can have a more robust antibody production. And they make that acknowledgement that there were some challenges in their recommendations because of the lack of data. But the task force it will be updating these guidelines on a regular basis as data continue to come. So this is the most challenging information. What I'm going to be sharing with you in a few next slides is how patients with rheumatic diseases can best prepare for COVID-19 vaccination. I know that some of you are not rheumatologists, so what I usually tell my patients and tell everyone that has a rheumatic disease, still discuss with your doctor how the frequency of your treatments should be adjusted so that you can maximize the benefit from the COVID-19 vaccine. But if the patient cannot make it yet into the doctor and some of your primary care, you can still help by getting just familiar with the simple modifications that are involved here and that I will be providing an overview. Okay, I have a question here from Stephen Kai. Any data on methotrexate adjustment for COVID-19 vaccination? Yes, and this is this first slide about the vaccination, how methotrexate should be adjusted. So for most therapies, ACR task force recommend no changes to them to be made with respect to interrupting, otherwise optimizing the timing of immunomodulators. Excuse me. But methotrexate is one of those that will require optimizing the timing of administration. So, and one more thing I want to emphasize: the task force says that there is no contraindication for the use of COVID-19 vaccine in patients with rheumatic diseases. Uh, in from the rheumatic diseases standpoint or the immunomodulator standpoint, even if people are having a flare, it's still okay to receive the COVID-19 vaccine. The only time that is really that the task force says that it's a no-go yet is if the person is in the hospital or in the ICU for any reason. So, but otherwise, these patients need to be vaccinated. We want them to be vaccinated. So, this is the modification that the task force is proposed for methotrexate. So the panel recommends that methotrexate should be held 1 week after each vaccine dose. So then will be held for 2 weeks. And the similar guidance was made for JAK inhibitors. These are tofacitinib and baricitinib. Okay, so it will be hold the medication 1 week after the vaccine. Okay. Oops. Hold on. Let's skip one. Okay. So abatacept is a CTLA4 inhibitor, and the reason that abatacept will require modification is because abatacept is a medication that interferes in the communication between T cells and B cells, which is exactly what the vaccine needs. It's a good communication between T cells and B cells, so then the B cells can produce the antibodies. So because of that, the ACR recommends that subcutaneous abatacept should be held 1 week before the first dose of the vaccine and 1 week after the first dose of the vaccine. There is no need to hold abatacept for the second dose. This is for the subcutaneous part. Now, you can postpone if you're on the infusion abatacept is given every 4 weeks. So the infusion should be postponed for 5 weeks after the exactly. So you need to postpone it, the subsequent abatacept dose by 1 week, and because it's happening every 4 weeks, then the subsequent dose of the infusion abatacept instead of every 4 weeks will occur in 5. That's what that third bullet says. Okay. Then for those not yet on subcutaneous or intravenous abatacept, therapy should be initiating following the recommended 1 week delay after the first vaccine. Okay. So Rituxan, very important. As I showed you earlier, Rituxan is one of the factors associated with worse outcomes in patients with rheumatic diseases. So assuming that patients' COVID-19 risk is low or is able to be mitigated by preventing health measures like self-isolation. So the schedule of the vaccination should be done 4 weeks prior to the next scheduled Rituxan infusion. Rituxan is given every 6 months. That is why the first bullet is so important. We are assuming that the patient can isolate for up to 5 or 6 months so that they can get that dose of the vaccine before the next infusion. But if the patient cannot follow all these things or do not want to, still, it's okay to vaccinate. Okay. So once vaccinated, what's next? I think that given the presence of the variants, especially nowadays and the rising in cases, and unfortunately we're seeing with this variant, mask wearing might not be a bad idea. This might still be seasonal. Once we have outbreaks, we may need to come back and wear them on a regular basis. And then once cases are low, we might actually be able to take them off. But especially for rheumatic diseases, I still promote the use of masks, especially around people that have not been vaccinated, because we really don't know or can predict who is vaccinated or not around us. It provides, there are protection against other variants, especially the Delta. Now, there's still data out there that is still investigated regarding the need for a booster, especially to cover for the variants. As they say that, between 4 to 6 months, some of these protection might fade away. But again, the CDC is evaluating not only the data that just came out from Pfizer, but also data from prospective cohorts. And this is again this protection for 6 months is actually demonstrated by data from Pfizer and Moderna on against the wild type SARS-CoV-2, the initial one, right? But for the variants, that is still under investigation. So I anticipate that, while we don't need it so far, I think, we might need it in the future. So to summarize our conversation today, the first part we talk about that the use of immunomodulators for patients with severe COVID-19 and cytokine is possible, but it still requires further investigation. We anticipate that these immunomodulator drugs that have been used in the past for rheumatic diseases and rheumatoid arthritis might benefit probably only a small number of patients with the most severe forms of COVID-19 and not every patient. So COVID-19 infections associated with increased risk for severe disease, or the most severe form of COVID-19, and mortality among patients with autoimmune diseases like lupus. Some of this excess risk was related to uncontrolled underlying disease activity. Now, Rituxan was another medication that was associated with worse outcomes. And the most important thing is that there is no contraindication for vaccination against COVID-19 for patients with autoimmune diseases, just modifications in the interval of administering these drugs so that people can get the most out of the vaccine. With that, I would like to thank you again for your attention. This is the information about the Lantern Lupus Asian Network. There's a phone number, support line, and all this magnificent work that Eliza's team does and her team does with lupus and patients with lupus and HSS. And I would also like to acknowledge all the investigators that I work with every day on trying to find explanations and answers to our questions. Please don't hesitate to contact me if you have any questions, any comment, any updated data that I did not present that you thought it was important. Please, here is my email address. And Eliza, do you want to say something else?
Oh, yes. Thank you very much, Dr.
You're welcome.
Very